A lot of exciting news there in the sessions you gave. I'm really excited to hear that Ahad has been roped into bringing his incredible energy, enthusiasm, expertise, and drive to make a FAHN gene therapy project happen. I couldn't be happier.
No, me too. I was so excited when I heard that.
Yeah.
And I'm glad Ahad's here because I didn't mean to rush through his slide there, but I would love him to contribute a little bit more about where we're hoping to go. And I know Dr. Messius couldn't be here today, but honestly, she's going to be such a valuable resource for us in terms of understanding this gene, this protein much better. And I honestly think having such strong groups working together really is going to be the most important thing here.
Yep. Takes a village.
So I know that Marilyn's running the show here, so for questions and things. So
from what I understand, you'll each have any questions been submitted?
No, I was in charge of questions. There were no questions submitted for FAHN, and I assume that's because we're just a little club and we knew we could just chat and make it less formal. So maybe you can show your videos, Sunita, and we can do whatever people want to do.
I just wanted to share. I wanted to share a video by one of our patients just because I thought I was going to end it with this because I found it inspirational. And maybe during this video, you can all think of some questions. How about that? One second. Give me 1 second to get it. Or if you want to start asking questions now, happy to do that.
I'll just tell you something, Dr. Hayflick.
Please.
Lance Swedish, his daughter with FAHN lives in Oregon.
Oh my
Really?
God.
Yeah.
Nice. Whereabouts?
They just moved to Sun River. So
Oh
my ex-wife Nina's mom grew up in Portland. So
great. Yeah,
they're in that area.
Sun River's nice. My family used to do reunions out there every summer. So that's lovely. Well, we're here if we can help with anything. Feel free to pass the information on that we're here to help.
Absolutely. I think you'll be bugged quite a bit.
In the meantime, hi, Michelle. Hi, Canada.
How are you?
It's good to see you again.
The Maple Leafs are coming together.
Absolutely.
I know.
So
Kyle is an honorary Canadian.
Yeah,
exactly. I'll just share this because this was one of our patients that made this video. So, and she gave me permission to share it with all of you.
My name is 5 years old, and I have an SPG certified. It's a real disease, but I can tell myself.
I can hear the sound, but no video, Sunita.
Oh no. Okay, I'm going to stop share and share it again. Can you see it now?
Yeah.
Okay, I'll start it over. It's short.
I know that little boy.
It's a real disease, but I consider myself lucky because I have the best mom in the world. I like to explore and genius things, and my mom helped me to do it. And then I share all people in the world, especially young people with disease. We should enjoy our life. However, the circumstances. So, come to my channel. And let's enjoy our time together. I love you, Wendy.
Nice.
So I promised them I would share it today. So yes, I welcome. I think I can start off by saying that thank you to everybody that has been part of all of the studies that we have, started in the last few years. And apologies to everybody about COVID, COVID delaying some of the. Oh, that's probably me. That's probably me. I'm so sorry. There we go. I'm like, who is that? So COVID has delayed some things just because of a lot of things had to be stopped. Research had to be stopped and paused, but things are back running again. Okay, so things are going to move forward with that, keep going, and the same kind of funding is going to keep us going with the studies that have been funded. Those of you who've been part of so far the natural history part of things, I mean, we want to move this as a prospective study, and now I'm fine-tuning the different milestones a little cleaner so that we can do similar to BPAN ready and PLAN ready, so that it'll be easy for you as families to input information rather than having it to be all physician-based or medical specialist-based, because I think that is important. And but I want to make it very clean and easy. So I'm going to actually reach out to Alison to make sure, and Puneet to make sure that my milestones are just as easy to capture as all of yours. And it's a little different, as you've seen with FAHN. There are going to be some specifics that I'm going to be asking for that are more unique to FAHN, to be able to just look at things more clearly, because all those curves that I showed you are showing us different windows of changes. And there seems to be a clean window at the very beginning that's not that short, but if we can, with all the basic science research that's happening, we can see whether those windows, if there's more than one window of opportunity here, not just a window that's just in that early phase that's pre-symptomatic. But can we halt progression if we get in between the onset and the time that a child needs a walker, things like this. And these are the things that we have to delineate more with the mouse models and with all of the cell lines that are being produced.
Actually, your presentation of the difference between what's in the medical literature now and what you're learning by asking specific, almost unbiased, or maybe they're more biased questions, but you're asking in a way, it's a really good demonstration of the importance of going straight to families and asking them kind of what are the important challenges that your family member is facing, and actually in kind of incorporating the patient or family voice into this whole scientific effort. You, just to underscore it all again, we can't do the work without you as active partners. And I know that this community is super small and super mighty, but just to reinforce how important it is that you all are here, you're engaged, you're contributing. And I also just want to call you out, Sunita, for really having taken this and run with it. It's been very impactful, and you've done just exactly the right thing, which is not to assume you can do it alone. You need the families, you need a whole community of scientists with all complementary expertise, but what you have is you have the passion, the drive, the leadership skills to actually bring this all together and shepherd it along, and that's fabulous.
I know Dr. Luo and I hope I'm saying your name right, have bombarded you with different types of information at different levels of understanding. So, feel free, if you don't have specific questions, ask us to clarify things. Ask us to go over some of the stuff in more detail. Like, we're here for you.
Talk to us.
Does anyone have a question that they'd like to ask Sunita or Dr. Hayflick or Allison?
I do.
Or Dr. Rahim?
Rahim, sorry. Go ahead, Michelle.
You mentioned that there were some projects that need funding. Like, Is there anything we can do as a group for that?
So I think where we're struggling, and this is the pros and the cons of collaborating internationally.
Yep, I understand.
The pros are that we have experts that understand the field, are passionate to move it forward. The cons are that a lot of funding agencies want to keep things within the country or within the province.
Yep.
And that's where we are going to be struggling, because these two projects in the UK and Germany that are moving forward, and this FAHN being a rare disease, it is, even if we look into the spastic paraplegia, the HSP foundations, the leukodystrophy foundations, even if we're not looking for large amounts, we need international kind of consortiums or people to come together and say this funding is not stuck to a certain person or a certain place, but to a certain project. And so the two areas that we're going to need immediate funding for is going to be with Dr. Rahim's project. And he can tell us more maybe about that, because there's 2 stages to his project. And with Dr. Messias, for now, Dr. Luo's project is running forward with the NBIA grant that was received pre-COVID. And the other part is the natural history. And you heard that from Alison, you heard that from Dr. Hayflick. The natural history studies are very hard to get funded. And so they don't take much funding, but somebody needs to be there as a research coordinator to call out, to keep track of patients, to be there for the families as in both directions. Mm-hmm. So all of these areas do require funding. So there is a call out to anybody in the community, any kind of philanthropists that are out there that you may know.
I know if you raise money in Canada and say the university that's doing the stem cells in Germany, if they are registered with the government of Canada as a donee, a qualified donee, I think it's called, then you can raise money in Canada and send it to the university or the hospital for that, but they have to be registered as a qualified donee. Or there's an application where they can apply to become a qualified donee too. It might make it easier to send money.
So our foundation at our hospital is setting aside money if it comes in specifically for FAHN research, as long as it's going towards FAHN research. So that's going to be easier to send out to whoever needs it. It's more when we're going into things like in Canada, it's the CHRI grants, or the big grants that to do high level funding for multidisciplinary projects. The main researcher sometimes, or the researcher that's doing the actual study, the lab work, has to be based in Canada, and that's an issue. So those are areas that are harder to achieve success.
Maybe this is an opportunity for you all, or at least you all who are in Canada, to educate your grant administrators. I mean, really going to the national grants people and saying, for an ultra rare disease, your sort of restrictions don't work for us.
No.
And since we pay your salary, because we pay your salary, we'd like you to imagine some exceptions that will serve our community, because we're Canadians, just like people with hypertension are Canadians, and we think we should get some of those grant dollars too. You don't underestimate the power of your voices. If people can come together, you can drive Kyle up to Montreal, and he can post something from Canada. Yeah. Don't underestimate the force of your own voices.
And same goes for the UK group, UK families, because same thing, right? If you direct it, if you do something within your own region, I mean, that would be very helpful as well. Families can come together.
Can you go through the NBIA Disorders Association and say it's for FAHN through them, and they give the grant to whoever needs it? Is kind of what you've been doing. Will that work?
Yep.
Yeah. So we can still do it that way.
Yeah, the only consideration there is that they need to get a certain size grant, and then they do an open call.
Right.
And although, having said that, we have done contracts with them for the PCAN best practice guideline. We did it as a contract, and it may be that Michelle, you might want to talk to Patty and see, can we do a contract with Sunita for a fixed amount? Then we know it's, $15,000 a year or whatever, $20,000 a year. And then we all know that this is a target we have to aim for every year to cover the natural history or something like that.
Okay, yeah, that's a good idea.
Does anyone else have a comment or question they want to ask?
I got a question. How much money are we looking at to get things rolling faster?
So Ahad, do you want to address for your studies what we're looking for?
Yeah, it's a difficult question, isn't it? So let me introduce myself. I don't think many of you know me. Sunita has brought me into this community as of yesterday. So
2 yesterdays ago.
I'm in London. I have a group that works on gene therapy for various diseases, and Amy, who's I've just seen popped up on camera, is in my lab. On my screen, you're at the bottom, Amy, but I don't know where you are on other people's screen. So different technologies they all cost different things, right? Some technologies are very expensive, some others aren't. We use mice, for example, which are quite expensive to keep them and to breed them. You'd think keeping mice in a cage is not very expensive. You'd be amazed as to the kind of pills that we get. Research in general costs more than one would expect. But my experience, I think Dr. Hayflick and Dr. Venkateswaran I hope will agree, is that when you work in the rare disease arena, you try and make do with the best that you've got, because there isn't a lot of money flying around for these conditions, and so we're quite accustomed to getting on with whatever we can raise. And without exception, so I work on, for example, gene therapy for 7 or 8 different neurological diseases. And without exception, this is what happens. You go to the patient family organizations like your wonderful organization that you have here, and they raise a certain amount of money and they give it to the scientists. The scientists then go away and conduct a certain amount of research, which we call preliminary data. Okay. And then what that then allows us to do is to go to bigger funding bodies and to say to them, look, we'd like to do this research in FAHN, for example. And we're not just saying we want to do research, we've actually got some evidence to suggest that what we want to do is going to work one day. And people believe things that they can see, right? So if they can see a graph, or they can see, for example, you had a presentation earlier on iPSC cells, for example. If they can see the evidence that things are starting to work, or there's a foundation upon which you can start to build your research, suddenly the question that you're asking, and you're asking for money, doesn't seem quite so far-fetched, because there's evidence to support it. So sometimes, I remember, when I first started out in this job, I was asking for £2,000 or £3,000, which is tiny amounts. It meant I could do a tiny little experiment, and then that allowed me to apply for £100,000. And then when I got that data, that allowed me to apply for $500,000, and that then went for 2 million. So it's a kind of a incremental process that you go through, and it's something that we're all quite accustomed to doing when you're working in rare diseases. It's a poor situation. Mm-hmm. But we get things done when we have the opportunity to do so. And like I said at the beginning, invariably it starts with all of you guys here, with your commitment and your passion. And also something that Dr. Hayflick said earlier is that you've got a spokesperson for you in Dr. Venkateswaran, who is incredibly vocal, incredibly persuasive, and quite inspiring also. So she's dragged Amy and I into this meeting because we want to hear more about what she's got to say. We really want to work with someone that's so motivational and can organize people really well. She's got the UK and she's got Germany involved now. Yeah. That's not easy to do, but she's injecting the time, and with your help, I hope that she'll take it further. So I think that's my message. But it starts small and it just grows exponentially, and the seeds are there. I can see that sitting from here.
Thank you.
So is there any way that we could, I don't know, have, like you said, if you have something that you can show people, I don't think I'd have any trouble raising money, but when you're saying just I'm raising money for research, they're like, okay, whatever. But when you have something like concrete where I can say, well, they're working on a gene therapy project in the UK. And if I had something to show, I could probably raise the money. But I
That's
need
a really
like
good
a-
idea,
something.
Michelle.
Yeah.
We've done that before in our fundraising efforts over the years. We've said, okay, we've got 2 discrete projects and we've put out dollar amounts. We need $30,000 for this and 20,000 for this. And here's the little thermometer going up as people raise it. It gives them something visual to look at. It gives them a target. There's a discrete goal. I think that's really useful. You just
Yeah.
have to carefully plan what you want it to be.
Right. And I know from my experience, when I first got started and all of this was when you're fundraising, first time round was okay. But then when you're keeping on going back, asking for money for research, they want to know what it is that they're doing. What kind of research is
Yeah.
happening? Where is it going?
Hmm.
No,
And
it helps.
what they do with the last,
Right.
donation I gave you.
I
actually
already
being
donated
able-
once.
Yeah, but being able to tell people your donations enabled and then fill in the blank. This
Right.
was possible because you stepped forward. Now
Right.
we want to go here and this is what it's going to take.
Yeah.
Why don't we build a roadmap together as to
Yeah.
what the beginning was, where we are now, where we're trying to go, and it won't look like a road. It might look like a bit of a web, but to show how things are growing, and then we can keep building on that. So we can do a visual and have some, and then as papers come out, we can put things in more concrete into this map, and you just have we can put something together. We can get started now. We have stuff we can put to some
Yeah.
visuals.
Yeah. You have an advantage also in one kind of, it maybe is a little bit out of people's view, but the fact that the FAHN mouse is a really good mimic of the human disease, unlike in pecan, right? In pelan it's true, and in FAHN it's true. In pecan it's not so true.
Mhm.
The fact that the FAHN mouse is a really good mouse model is among the most important sort of fundamental tools that enables therapeutics development and discovery.
Yeah, well, the other thing I would say, Michelle, is maybe thinking outside the box or, expanding your vision. Like we had this pecan family that was involved in real estate development. They had all these contractors and people donate either their time or donate things at cost, and they built a house and sold it and donated the money to Pecan. I mean, they were
heard-
thinking big, but by and those people, everybody who donated their time or who donated raw materials got recognition for that. And there was a lot of fanfare and media, but there are ways to leverage all those things. And the other thing we always leverage are adorable children driving little cars and, doing backflips off boats. But it's anything that, tugs at the heartstrings and relates to people. But
Lemonade stands.
I know Gina, she's like their family's done a lot of fundraising. Do you have anything to add to that, Gina?
I think with more material, like what Michelle said, because I know we have a lot of friends and Kyle has a lot of followers, ask questions all the time. And they've recently been asking, do we need anything else? And do we need to start new funding? And I said, yes. See, last year we didn't get too far. So if we have the tools to work with, we could just get started again.
If anybody can do it, Gina can raise the money.
and Kyle.
It wasn't easy.
But even, when we were trying to raise money for the pecan trial, the Coasi trial, there's a group of girls down in Butte Falls, Oregon, who had a lemonade stand, and they sent me an envelope with about $6.81 in it, kind of all of the kind of grub.
Oops.
Because they've been doing it, everybody can help. even if it's just $100 that you collect from 15 people, everybody can help.
Yes, I agree.
And remember, this is all going towards like the actual, because this is rare disease, everything is going to go, and you can reassure people it's going towards the actual materials and the people that are working right onto it. It's not going anywhere else. It's going to be directed direct.
Yeah,
to
no
the
profits.
I
Yeah.
got a question.
Yes.
I'm just wondering if the labs had a GoFundMe and it go right to those scientists. That way people don't think you're scamming, stuff like that. And the money can go right to the labs. I think you got a better chance of raising the money that way.
I know
Get
that.
doctor's name or something on it.
Yeah, I know we're not allowed to do that.
Yeah, most of our universities put
Oh.
some restrictions around that, because as you might imagine, at a university with 400 scientists, if there were now 400 GoFundMes, it kind of creates a little bit of havoc. And most of our universities have a foundation, a nonprofit place where donations can come. Yeah, I think that would actually be challenging to do. But I like the way you're thinking. I like that you're thinking creatively.
Yeah, I'm just trying to figure out a good way to do it.
Yeah, our foundation does keep the money aside, and then I can allot it to anything. I know they are keeping it aside just for fun.
So you have a foundation at your lab? Can we?
Yeah, we have a foundation at our hospital that will goes directly. So it's the CHIO Foundation. I can put it into the chat, and it wouldn't be for any kind of study that's outside of FAHN.
So can you do a GoFundMe or something like that for that foundation?
Yeah, you can do it separately and then donate the funds to the foundation.
And that would go directly to FAHN.
Yeah. Yes, exactly.
So maybe if we could come up with some kind of fundraising campaign and have it go directly to there, we could do it that way. At least we know it's going for FAHN and it's going where it needs to go. And it could give some legitimacy to what it is that we're asking people for. Maybe.
I can give you just to have, if there's if there's individuals, I'm just going to put the person in. This is the person that you would, her name is Jacqueline.
I think I might have talked to her before.
Yeah. So
Yeah.
she runs all of this.
Actually, she might be somebody, Michelle, for you to talk to, and just, I mean,
Yeah.
again, and just hear, what are the myriad ways. And then we have these collaborators in other countries. It might be simple for them to do this, donee registration, but there might be just easier paths. I mean, if
Right.
Ahad doesn't have to spend an hour doing another form, I'm sure he's going to be happier. We have plenty of that stuff we normally do.
And I've never applied for charity status for NBIA Canada because of all of the international restraints. Because the disease is so rare and 90% of the research is from the NBI Disorders Association, or in Germany, I couldn't do anything with it because I wouldn't be allowed to help them. So I can't even give a tax receipt through NBIA because we can't give the money anywhere outside of Canada. So we're restricted that way.
And I'm going to be presenting this research actually in a shortened form at the United Leukodystrophy Foundation next month. So I'm also going to be searching through them to see, because honestly, I think research in FAHN can help many other leukodystrophies. So so that's in a few weeks. So I'm going to also inquire with them as to where American or international fundraising. This is an international consortium of scientists and families. So I will inquire for all of you as well. There was a question in the chat. I'm going to find out for you, myself or Gina can find out how to get the recording from this morning.
I think they'll all be posted. I think actually all participants will receive links to be able to watch any of the recorded sessions at a later date. Yeah.
Okay, I just shared that with everyone from Delphine because she couldn't get on.
Yeah, excellent. I think it's and the work that Dr. Luo's group is doing, Dr. Herman's group in Germany, they're working together, has been funded from the last NBIA Disorders Association grant. So you can see that that's going to have a huge impact as well, because that research is going to really, I mean, developing iPSCs, I didn't think I'd ever get to be involved in things like this. And using, you know, having all of you contribute and then me being able to help contribute what you've contributed to them to allow their research to happen. This is how it goes, right? It's step by step, and it all leads to from one thing to the other. And so you as families, just providing your, you know, information, samples, all of these it's not a one-time thing. These are kind of held and can be produced for many, many other studies with your permission, you know, consent. So everything you're contributing is extremely valuable.
Does anybody have any questions about any of the therapies or that you're using now, or issues that you wanted to ask any of the doctors? Like, if we're finished with the research, because
yeah.
I wondered if you know, I know we have issues with tone and spasticity and bowel and all that fun stuff. So did anybody have questions they wanted to ask now that the
I do.
expert here?
All full of questions. So I'm a little bit confused because some of this stuff goes over my head quite a bit. The stem cell research, did I hear the doctor say that that was CRISPR, or he used CRISPR to get the cells that he had or something?
Dr. Luo, do you want to? Here, you can unmute if you'd like. So I think he was just referring to, so that was one way for him to get that specific mutation within that cell line, and versus skin samples that we already have that already have a specific mutation in them, dependent on the family, the patient that provided them.
Right.
And so that was to get something very specific, is why CRISPR was being used.
So how would the skin cell therapy, what would that, like if it were to work, what are we just screening for drugs with that one? Is that what we're doing?
So first of all, what he's doing, just because I don't know if he's coming on, he's doing is he's taking them back to their infancy, right? He's taking the skin cells and then reprogramming them to be back into the cells that can produce any type of cell. And then they're going to look at specific brain cells, neurons, those that produce myelin, those that, you know, produce the supportive environment, the astrocytes. And then he's going to look to see whether they're different or the same, first of all. Are there differences in how they're developing, growing, changing within controls, meaning age, people of the same age. And then following that, I mean, it doesn't just, this is the part that gets complicated, because it's not just that and that needs to be done. Then they take it further. If there are differences, can they reverse those changes? But the same kind of similar kind of methodology will be happening with Dr. Rahim's lab as well, because they're going to be looking at the, can things be reversed in the mouse? And then these kinds of cells, and I may be explaining this completely wrong, but these kinds of cells later on a wide array of drugs can be applied to see whether there can be changes. But first of all, we have to see, are there differences? What are the differences?
Okay.
Before we can try to make those, reverse those differences and see if there's an impact in a positive way by reversing them.
So that's the stage that he's at right now, is to see what the differences are. Is that right?
Exactly, to see, are there differences? And if so, what are they? And yeah, so at the very, I mean, this is all very preclinical. Yeah.
Have you heard from the doctors in China?
No, we haven't. I wanted to wait for today to have a discussion and see if they were going to join to hear more. So not yet. I will engage with them after, because I'd like to hear what's happening in their research and more details about what's going on and how. So do you want, you actually know most, Michelle, but do you want to talk about this, or do you want to talk about more of the symptom?
I can tell you what I know, which isn't a whole lot, but there is another FAHN family in Canada, and they have funded a gene therapy project in China for her son. And I really don't know much about it because there's, you know, a little bit of a language barrier, plus the doctors in China, and it's really hard to reach. But as far as I know, they're currently testing, I guess, the treatment in a mouse model. And they're waiting for results to come back from that. And it's possible that it may even be this year that this treatment might be available to her son. But I don't know anything else other than that.
I think it would be important to have a really good discussion about this, how it's being put forth and like how it's being done, what are they looking at?
Yeah.
And just we need to understand it better. And so that's
I've been trying.
Yeah. So I will communicate with them. It was a few days ago. I wanted to see if they would join and give us some information about this, because I really don't know much. Nobody has reached out to us. So it's just I will reach out to them now.
Did your email bounce back? Did it actually go
No,
through?
I haven't attempted to reach out.
Yeah, because I've tried a couple of times and it just keeps coming back to me. So
Okay.
it's really hard to make contact.
So I will do my best.
Okay.
Absolutely.
So that sounds really promising too. Who knows?
Mm-hmm.
Yeah.
Hey, Emma.
Anybody else have comments, questions, anything they want to bring up?
Happy to discuss like different treatments, different, whether it's to do with seizures, whether it's to do with tone management, with swallowing, with any of that.
Do any of the kids have questions,
Do you have any questions?
including adult kids?
Yep.
Trevor? No.
Any questions about the differences in tone and how the treatments vary? Because I know that can be a really tricky situation.
Yeah, I got a question. He's on an air breathing machine at nighttime to get better rest.
Yeah.
That machine.
Just wondering about it because I know our son Landon, he's very tired all the time. And I'm just wondering how that works, like if that's a good route.
Sorry, I missed the last part of the question.
Is that a good road to go down? Does that help?
So I'm assuming it's a CPAP or a BiPAP, nocturnal BiPAP machine. So it's allowing his lungs to expand better during the night, allowing him to oxygenate better.
Yes.
I think so, yes.
Yeah. So yes. So this is something that's used in any child or any young adult that has difficulties with respiration, whether they're pausing in their breathing or whether their muscles are weak, anything that is preventing them from breathing on their own. So it wouldn't have any detrimental effect. It would be a positive thing to have that, because then it's not allowing it's keeping his oxygenation at the right level, above 90, 92% over the night, and making him work less. So he should be less tired during the day, and no headaches, things like that, things that are common symptoms that if you're not on that kind of machine.
Okay.
So does FAHN affect their respiratory system? How does that work?
So it's not directly affecting your respiratory system, but based on the fact that the muscles in the trunk can be weak.
Yes.
So because of that, the ability to expand your lungs, because you need a lot of these muscles, these intercostal and your diaphragm, to be really strong, because to inspire and expire properly. When those muscles, when you have low tone, you end up having more work you have to do, the less ability to do that. So in any condition that causes low tone or muscle weakness, this can happen over time, which is part of the reason it's important, if breathing patterns change, to have a lung function, a respirologist involved, to have your vaccines like your flu vaccine, your Pneumovax, all that kind of stuff to prevent you from getting a respiratory infection, to be well nourished, because all of that can allow to increase your muscle bulk and make your work of breathing easier, and also to monitor the spine, because remember I mentioned scoliosis, because when you get scoliosis because of low tone, that can also change the way your lung looks structurally and to change the way the breathing pattern is. So yes, it can happen, but it's the kind of a point that converges from many different conditions rather than it being specific to FAHN and the lungs.
The other thing I might say about that is that people with any kind of condition that weakens their muscles or weakens their sort of their ability to keep their whole breathing pathways open, that can actually be kind of a silent problem for a long time, because we're not there at night watching your kids or your loved ones sleep. But it can cause sort of problems over time. And so it's actually, it's something to ask, or something to consider, something to observe yourself in your family member and understand if they're sleeping comfortably, if they're waking up and not feeling well rested. It's worth considering whether nighttime, what's called positive pressure breathing, it just eases the effort to breathe at night a little bit. And it's been found to help a lot of adults who snore and wake themselves up every 7 minutes with their snoring and never actually get a good night's sleep. It's been found to be helpful for them, but it actually has quite significant benefit for people with muscle weakness conditions.
I'll mention the other silent thing that creeps up on people is the swallowing part, as many of you might have noticed. And that's one that we don't want to miss. And so as part of, when I'm doing the clinical guidelines, I'm going to be emphasizing the fact that that needs to be assessed early and frequently so that nobody gets into trouble with aspirating and still enjoy. I mean, there's a balance. You want to enjoy food. Food is a big part of life. Food is a big part of our enjoyment. But you want to be able to balance that with the time and effort and the frustrations that may be associated with the enjoyment. So checking swallowing in addition to respiration early and frequently will be an important part of this to make sure that everything is being done, everything is going down safely.
So how early do you start looking at G-tubes then? Because Landon is still eating, but he does have swallowing problems, but he's gaining weight. I mean, he weighs over 80 pounds.
And so there's another balance there, right? Because the weight gain in itself may not be is one of them. If you're not gaining weight, that's one of the red flags. But you may be gaining weight, which could also be gaining too much weight, and it can be detrimental as well to your bone health, to your posture, to all kinds of things. So the weight gain, as if it's an appropriate weight gain, that's great. But if there's time, if it's taking a lot of time to eat, or if there's frequent coughing, or you're having to change the way the feeding is being done, cutting up things really small or avoiding liquids altogether as examples, then it's time to discuss it earlier than later, because first of all, it's something that's reversible. Secondly, it doesn't prevent your child from eating orally. It may allow your child to eat orally safely and enjoy the foods they eat, and may not make dinner time a struggle. And so you could give, and a lot of nourishment can then go through at night, whereas the daytime can be smaller, more frequent, fun meals for the family and for the child. So I usually encourage families to talk about this early and not to be, it sounds like such a scary thing to have a tube to feed, but it's not. If the G-tube goes in, doesn't mean you can't put anything in your mouth. It complements oral feeding.
So really, we should look at these things before it becomes an issue.
That's what most of us recommend, I would say.
I don't know why, but it seems like such a hard thing to, I don't know.
I don't know
about that.
And I think there was a session on that on Thursday, correct? Because this is a struggle for all families and for all kids too, right?
And actually, Allie's had the surgery and it wasn't bad at all. And she has just a cute little button on her tummy that it's easy to cover. People don't even realize she has it. And it made our lives 100 times easier. She's much healthier. It is scary. We didn't want it, but it was never really explained the way Sunita just explained it either. We had the vision of always on this pump with a bag, but it's not like that.
Allie seems pretty happy about it.
You can eat what you want during the day, and it's not, eat those vegetables because you're getting them at night.
When they're eating, then it's just enjoyment more than like they're getting nourished, they're healthy, and then just eating to enjoy being able to eat chicken nuggets or whatever.
Yeah, and like they have so much other regulation in their life.
Yeah.
If you can eat something that tastes good and you like, and just enough to make it that you're happy, it truly makes your life a lot better. Not that we didn't have a learning curve.
Yeah.
And, reflex vomiting of this food I put in too quickly or too soon after she ate, or, but it's
She
not
gets
that bad.
too. She gets that too. Landon does sometimes too. If he drinks like milk or yogurt, it just comes back up.
Well, no, it was more, it went in her tube. So maybe she ate, maybe she went to bed. Like, I've learned I have to wait a certain period of time after she goes to bed, because maybe she still has too much in her stomach or her sleeping position. And she did have scoliosis, which also put extra pressure on her stomach. But now I know the proper rate to use. Like, you can rate it from like 50 mils an hour to 200 mils an hour. Like, you could make it just drip all night. And then if they wake up, they're not starving, and they can have something they like to eat before they go to school, and you're good to go.
Right.
And a lot of that reflux that you're saying, and the reflux and the vomiting, is also when you have low tone outside, you have low tone inside too, right? So your GI, your gut motility is different. And so things don't necessarily get propulsed the right way. They can go the wrong way too. So a lot of the things you're explaining make complete sense with, your experiences.
I'd encourage people to talk to other families. So you've heard from one family, but talk to families with other NBIA disorders, and just hear, what was your decision process? What kind of pushed you to finally do it? How'd you feel before? How'd you feel after? And just hear from other families, because we can give you all the data we want, but actually understanding from other families what helped them, I think, is very instructive.
I think too, Mary Lynn made a really good point, which is there's absolutely a learning curve. And what you don't want to do is experience that learning curve in the middle of a crisis or an emergency where you're doing an urgent G-tube, which we've seen in PCAN several times. It makes everything so much more stressful. And it's already hard. So being able to control a little bit more and choose when you're going to do it, I think it helps.
The constant water infections. Is there anything we can do to try to stop that?
The bladder, did you say bladder infections?
Yes, constantly, all the time.
So that's a tough one. I mean, it's finding out what's causing the bladder infections. Is it because there's a lot of retention happening? Is he not being able to pee when he wants to pee? Or is there another issue? So that needs to be investigated. And some children may have to go on some prophylactic antibiotics for that. Okay. So that should be looked at, because you don't want that to become worse and then become a stronger infection that then goes anywhere else further up from the bladder.
Okay.
We had it investigated last summer with an ultrasound thing where they fill his bladder with water.
Yeah.
But they couldn't finish the test because he had a severe anxiety attack from the pain, and he wouldn't pee. So we never did get any results.
Yeah. It's a very simple thing, but you can also just manually with your hand. So if he's having, just again, because of muscle weakness, having trouble completely emptying his bladder, you can put your hand just above the pubic bone on the front and just gently push kind of in and down. So he does his peeing, and then you try and do that, and with sort of slow, sort of consistent, gentle, but firm pressure, you can sometimes get a little bit more out. And it may be that if there isn't retained urine, but I would agree with Sunita that he needs more investigation of that, because it's not, we wouldn't expect people with FAHN necessarily to have recurrent bladder infections. And so there may be one other thing that's going on with Landon that could be taken care of with either medication or small surgery or something. So it's worth investigating. And that doesn't require a FAHN expert. That requires just some good healthcare.
Okay.
Yeah.
We have a couple of questions as well.
Please go ahead.
Emma is following a ketogenic diet, which
Yes.
was first started out of consideration for the abscesses that she was suffering, which improved a lot, but had actually a very positive effect on the muscle tone as well.
I was waiting for you to bring this up because I wanted to see if any other family was going to bring some experience up with this. And this is where we learn from you.
Mhm.
I haven't had any other families to date tell me about any experiences on the diet. You're the only one.
Yeah.
And I do recall our conversation, and she's still on the diet now.
Still on the diet, and we actually went off the diet in the summer of 2019 during 2 months, and without telling the physiologists, they observed a pretty severe increase in tension in the muscles. And when we started the ketogenic diet again, they again observed the radical decrease in tension in the muscles. So from an objective point of view, empirically, there was, without a knowledge and bias, a actual effect that was notified from the ketogenic diet, which is not captured within the advantages of the ketogenic diet as such.
I'm curious to know, can we investigate that in the mice? Ahad, I think that would be really interesting to look at, just because of its implications, and like obviously with the increased lipids and low carbs, and then I don't know what else it does in terms of the lipidomic profile, sorry. It's something that I wanted to, really good to look into.
Oh, and it helps in the focus as well, in concentration.
Yeah. And that we see in our epilepsy patients as well, in terms of focus, for sure.
But that's a known side effect of the ketogenic diet, if you want.
Right, but the tone managed, I am interested.
The muscle tonus was not.
Yeah, no, it's a very interesting aspect that we need to look into.
Yeah.
Because it has the ketogenic diet, just for others who don't know, it's not the ketogenic diet that we see on TV or in the books. It's a very high ratio lipid, almost all lipid, protein, very, very little carbs in your diet, can cause metabolic acidosis, can cause some severe derangements in our body if not done properly, hypoglycemia. So this is the true ketogenic diet that Delphin's discussing, or they're discussing right now for Emma. And before embarking on that kind of diet in its strictest way, we need to understand it a little bit better. But Emma's got a good reason to be on it, so I'm just plugging in my computer.
No, it's a great example of families teaching us, right? So your experience with Emma is telling us that it's important that we do some experiments in the animal models, where we can manipulate things more easily than we can with a human, right? And so now we should just, in the experiment you've just discussed, doing a lipidomics kind of experiment before and after. I mean, I think that's really, really interesting.
I think that would be very doable in the mouse models, because there are a number of studies on ketogenic diets for, as was mentioned before, for epilepsy, for Dravet syndrome, for all these different neurological conditions, which a lot of those animal studies are already taking place here. So we can learn from what others are doing and implement it in the model.
That's great.
That's very good. And the second question we had, which was not a question out of experimentation, but out of need, is if any other parents experience a problem in falling asleep.
Sleeping.
Yes, we do.
Yeah.
So falling asleep. Once asleep, the problem does not.
Yes, Landon doesn't fall asleep easy. He can't sleep very good. He's trouble getting to sleep.
And I don't think he sleeps very sound either.
No,
Yeah, we got the same problem here.
okay. Because Emma gets 2 milligrams of melatonin at night to fall asleep, but if she does not fall asleep within the first 15 minutes, it does not work.
Yeah, I hear you.
Yeah. So that's more of a general question and remark than anything else.
Do you find that the falling asleep is once she does fall asleep, the times that your children do fall asleep, they stay asleep, or you're finding that sleep remains restless throughout the night?
I would say that once they fall asleep, they remain asleep.
Because I know that
she sleeps very restlessly, but she doesn't wake up.
Doesn't wake up. Okay.
I am.
I'm going to need to jump off and join the MePAN meeting. So I
Yeah.
just want to send my hugs and affections all around. Ahad, I couldn't be happier, Amy, to have you joining this. It's awesome. So thank you. And I'll see you guys a little later today.
Thank you.
I don't know if we have to come off or if we're allowed to stay on. I can stay on for a few more minutes if we're allowed to be on the Zoom.
I should think we could stay on.
Okay, well, let's stay on because I can address some of the sleep questions. So sleep, just for in general, melatonin, we all know we all have the melatonin hormone that surges when it's dark on the onset of sleep. And so it's naturally within us. And then melatonin, when we give it as a supplement, we can actually give quite high doses of it. There isn't a wrong dose. So 2 milligrams is a small dose. We can go 3, 5, 10. It works or it doesn't work. Some people it works for. Usually we give it within 20 minutes of wanting to sleep in a dark spot. So they should already be in their bed. They should already be in the darkness. Then the melatonin is given. And then if it works, yes, in 20 minutes or so, your child's going to fall asleep. But if a small dose is not working, there's no harm in asking to go up to a higher dose. It's not a sedative. It's not addictive. So as long as it's not mixed with anything else that's in it, you've got, the actual melatonin, there should be no problem going higher and trying it out. Obviously, there could be many reasons your child has trouble falling asleep. For me, it's very different from a child who wakes up many times during the night. So I would still pursue the melatonin and also find, and keep sleep as routine, obviously, as possible. During COVID, it's easier to do, but keeping it routine is very important for the child. And children at your age, at some of the ages here, children need between 9 and 12 hours of sleep. So your child may be a 9-hour sleeper and it's too early versus one that needs 12 hours. So, and these things change during puberty too, right? The needs change. So these are some things to talk to your pediatrician about, because sleep is a very, I'm not sure yet whether these are FAHN specific or not. And I think if we start talking about sleep disordered breathing and other things, then we have to think about consequences of FAHN affecting the body. But if it's more of a falling asleep issue, it might be just a general sleep issue that many children undergo. Hard to say at this point.
Kyle sleeps very well with his CPAP machine.
And
indeed, that you said on Thursday.
And Gina sleeps very well because I have a CPAP machine too. Otherwise, she wouldn't sleep too well either.
Although Kyle does wake up between 4 and 6 in the morning to use the bathroom.
Yeah.
So he'll be in bed, I guess, between 10 and 11 and be up between 4 and 6.
And you all, as everyone knows, every child goes through 5 to 6 sleep cycles per night. And every child and adult wakes up every night and we just fall back asleep, right? You go to stage 1, you fall back asleep. But some kids, or especially later in the night, you might be light enough that you're just completely waking up or having a very small trigger getting you physically awake and not being able to fall back asleep right away. So there's so many factors in this.
Like with Ali,
So what we do, and that's more to spread the dosage, is we give her a last dosage of baclofen at 11 o'clock our time in the evening through the feeding tube. but it helps also in keeping in remaining calm and remaining asleep.
It's a
But
really
it
good.
was not a big issue per se, but it helps to spread the dosage. We know that baclofen is something that is sleep inducing. It makes you tired.
And a very good point actually you make, because sometimes it's like maybe it's tone or something else, pain that could be waking.
It's pain and tone. When she wakes up, it's pain and tone.
Yeah. And so this is when you have to look at treating other things that may be interfering with sleep during the night.
Yeah.
So that's why sleep is so complicated, because there are so many things that can interfere.
It could also be if your child can't roll over on their own, that like we roll and don't even wake up, but if they're on one side for 4 hours and they can't roll over to the other, that's when I find Allie's up, roll me over, roll me over.
Yeah.
What about like Zeplicone and stuff like that?
The actual meds, I don't recommend them in general for pediatric patients. I find sometimes the side effect profiles are too much, and you also don't want to reduce some of the meds that are out there for sleep can also reduce tone too much, and you got to be careful about that as well, right? Because then that can in effect cause problems with tone everywhere, and then can cause problems with breathing or other things. So we have to balance that.
Okay.
So I don't recommend those kinds of sleep meds, trazodone, all these things for kids.
Okay.
Really try to find out all the other factors first before we medicating.
Do seizure medications usually make the kids more flimsy, like more relaxed? Because Lennon is on clobazam, and Dr. Buckley, his doctor, told us that it has the same effect as baclofen. So sometimes he's too floppy. Does that make sense?
Yeah, and I was going to name clobazam as one of the drugs that could cause more tone changes, decreased tone, sleepiness. There's something like Keppra, for example, typically doesn't cause much sleepiness, doesn't cause tone abnormalities. So a lot of our medications don't. Clobazam falls under the category of a benzodiazepine, which does cause more sedation and tone changes. It's similar, but not the same as baclofen in terms of how it works, but it has some overlap with it.
Can I ask the doctor to change him? Like, am I?
Yeah.
Can
No,
I
if
do
you
that?
find it's interfering with, he's making him too sedated, absolutely.
Because the
You
other
can-
parents were saying their kids take Keppra.
Yeah.
Right.
So Keppra is, Keppra can, if your child has behavioral abnormalities of any sort, Keppra can aggravate those, or if you have mood disorders, sometimes it can aggravate mood issues, but Keppra and its newer form, brivaracetam, can also be options. There are lots of different options depending on the type of seizures. So for example, absence seizures that we brought up before, we use ethosuximide, valproic acid, lamotrigine more than Keppra. They work better. For other types of seizures, generalized tonic-clonic, depending on the whole, like the side effect profile and your child helps us decide on which antiepileptic we want to use. Because sometimes the side effects are good for your child. And for example, if your child's not eating enough, valproic acid might be a good option because it increases appetite. But if your child's eating too little, you don't want to start something called Topamax because it's going to cause you to have appetite suppression. So we have to look at all the side effects and what else it can help with, and then look at your child and put it all together.
Is there anything else that anyone would like to comment or ask questions about to anyone?
I have a question about the eating and drinking. So Brody is still active. He walks with a walker and he only weighs about 65 pounds. So we've tried adding extra calories to his food, but it doesn't, I don't know, his doctors don't really see it as a concern as long as he's maintaining the weight. And then, so I guess the question would be, is there anything else we could do to add extra calories, or is there any easier way to add weight
So yes, so this is the time where, I mean, we want to make sure he's maintaining, he's not falling off his curve. So if he's following his curve, a lot of times people aren't as concerned. One important thing is though, increased tone of any sort, whether it's spasticity or dystonia, is using more calories than in a person who doesn't have increased tone. Okay, your muscles are consuming more calories. So increasing calories may be enough, but sometimes if you have a dietitian or nutritionist that can look at him, and also making sure that the calories that he's consuming are going to help with bone health, keeping his bones strong, that's going to be important too, that he's getting the right increase in calories. I would, if he's maintaining his weight on a curve though, with how much you're nourishing him, then probably not much of a concern.
Okay.
And he's not struggling with the feeding aspect of it, then that's also a good sign. Okay.
Okay. And what about pushing liquids, trying to make him drink water? I mean, he'll eat food, but the liquids he doesn't. And I don't know if that's part of the swallowing or.
That's the one thing to look at, is it part of swallowing, and also looking at what happens at the other end, like bowel movement wise, or is he constipated? Is he having enough that he's voiding? So a lot of times we check about how much liquid intake we have by how much we're peeing during the day. So if he's peeing enough during the day, it means he's somehow getting liquids in through his foods, just through his other foods. And so voiding is a good measure of that. And but if you find that he's dry, he's constipated, and there's a struggle with getting liquids in, not because he doesn't want to, because he can't, that needs to be looked into.
Yeah.
We had the same issue with Emma, which we resolved through the feeding tube actually, to get enough fluids in. Because we kept thickening fluids up until the moment that she didn't want to drink anymore, and the solution was the feeding tube.
Yeah, we tried everything, water, cola, all kinds of tastes.
But in the end, it's just a general reluctance to drinking, and the only solution was the feeding tube, which is positive enough for us to now have decided to go for Emma, because it's her body, of course, that Emma decided to go for the belly button for feeding purposes.
And it takes off the pressure of the family in
Yeah,
drinking. Does she have enough fluid?
Yeah.
How much did she drink today? Oh, Emma, you still have to drink today. Please drink your yeah, just one glass of water. And now it's yeah, the struggle is, we don't have the struggle anymore.
It's really, really valuable to hear this. I think it's important that all of you discuss this more, because there's a major fear factor, right? So
yeah.
But it was a huge step to take.
It was an enormous step.
Yeah.
I mean,
it was.
En nu, ben je blij met het? Ja, het kriebelt, maar.
it is definitely a huge step, and has to be approached very gingerly and gently, and for both the child, especially, as well as the family. But seeing it's just it's a topic that if we need to just keep discussing.
Do you recommend the COVID vaccine for the kids?
Absolutely, I will say yes for those. I know today was the day in Canada 12 and up was allowed. You sign up.
Questions.
If your country is allowing 12 and up or whatever age, I would say yes. What is the COVID vaccine? The COVID vaccine there's no contraindication because you have FAHN for the COVID vaccine. What is it doing for you? Even if it's protecting against a small respiratory illness, that's good enough for me. Okay. And as well, obviously for parents, you having the COVID vaccine is going to protect your child if your child is too young to have it.
Okay. That was one of my questions that I was waiting on.
Yeah. No, you know, we briefly had discussed it and it said, yeah, it's, yeah, I'm absolutely 100%. Your children are not in a, they're at, I mean, there's a risk that it would be harder to tolerate a respiratory illness rather than a risk of having any kind of, I don't want them getting COVID.
No.
It's the bottom line.
Side effects from the vaccine?
It would be just the same as any other person out there in terms of side effects. There's nothing specific about FAHN that would make the side effect profile different.
Okay. I think that was all my, oh, I did have a question if Dr. Liu's research would be shared.
Yeah, yes, you asked that in the chat. And so, yes, so part of the agreement about the NBIA Disorders Association grant was that this is going to be shareable. So this research is actually going to be these cells are going to be open label. So Dr. Herman, who is the head of the lab, and myself, and the only reason I've joined in this is because we want to have international representation, is after these cells are produced, if another scientist wants to use these cells for their research to go towards FAHN, we want, as long as it's ethically sound, we will give permission as open science to have this happen. This is not supposed to stay in a lab. Okay, this is meant to move things forward. And so we've signed an agreement between the two of us that this is what will happen in the future, that it's in this way, having North America represented and Europe represented, it's helpful that both their signatures are on this contract so that it can be open label anywhere. Okay.
Good, okay.
So the cells don't have to be made over and over again, kind of thing. If these are the cells that need to be used, these are the cells that can be used.
All right, so it looks like fundraising has to start, Kyle. Once again.
So next steps, prospective wise, I'm going to go ahead, whether or not funding is there, okay, to move ahead with creating an open portal. Rare Connect has a FAHN group in it. Rare Connect is also through Rare Connect, we'll be running a study this summer for your experiences. We're not allowed to run it in Europe due to some the regulations that are there. So we're starting it in Canada, and it's going to be open beyond FAHN to any child, any family affected by NBIAs, because we want the caregiver's perspective. A lot of these questions about G-tube and sleep and stuff, I want this stuff to come out so we understand it better, and so we can actually approach symptom management better. Or if there's something new that's coming out, an experience we need to deal with, then we can do that. So that's going to be happening. The prospective part is happening. These studies are happening that you've heard about already. And yeah, and then manuscript's just about done for what I presented to you today. Okay, to be published. I was waiting for some more structure stuff because I wanted to make sure that we have those structures where all the gene mutations are sitting from our study, so that we've got those. I can also put them in. And as things happen, what I'd like to have is, I know we have a newsletter come out, and if one of you can organize that for all the families, so I have one place I can send it, and then it can be distributed to any family that wants it, that would be lovely. Then we can do research updates. Okay. Or yeah.
Michelle?
What's that?
Will that be you, since you have the whole
Sure.
website?
And I can do that through our website as well, and you can link people to the website. There are ways to do it. We can discuss that, Michelle. But that way you can look up updates as needed rather than in one place. I think that would be easier. And we can ask everybody to try to put their updates in one spot.
Can I ask one more question? I'm pretty sure like the gene therapy is something that we're all like really, 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 really excited for. What can we do as a group? Is it just the fundraising right now, or is there something else that we can do? Because, I want to get that started.
I think right now, you can speak it, yeah, if you want, but I think we can start with the fundraising. Yeah.
Okay.
I think that's a fair comment. It's the funds which really kind of hold hold back on the research, as you can imagine. So I guess the sooner that takes place, the sooner we can start the work. I mean, Sunita and I and Amy are dedicated to getting this up and running. We've had the conversations, and we're eager to start the work. But if you guys are able to mobilize and come up with a mechanism to get the money where it needs to be, then that would be great. I understand that these things are complicated, but I'm hoping that you guys can find a way to overcome that. It sounds to me like that charity that you've established at your hospital or at your university is probably the easiest way to do that.
Yeah, I mean, the foundation will, I can easily get the funds over through the foundation if that ends up being the easiest route. It won't go anywhere else. But then, yeah, and they will accept international funds. I know that because there's been attempts to do that. And it wouldn't stay within, it would go through a project, obviously.
So
if
the
we could
project
raise-
is not in Canada?
No, it can go to any project.
Okay.
It could go to any project where, as long as I guess I have to be collaborating on it.
Right.
That's all.
Which makes sense.
Yeah.
So if we had the money for the research to keep going, is there any way to give a timeline maybe of when something could be available?
Is fall too ambitious?
Not for me.
To achieve what?
To get some funds for no, because right now the vector part, it's just at that, for the mouse, to bring the mouse and get the mouse.
Yeah.
And how much are you looking for them?
So for the mice, usually we kind of cost mice at around about, I don't know, probably about £20,000 a year, usually. I think that would allow us to do some of the animal work to show that what the hallmarks of the disease are in the animal. And then we've already kind of started at our end making the gene therapy part. So I think that's probably the kind of sum that we would be looking for.
And for the structural end with Dr. Macias to look at the function of the protein in a different model, we're looking for about, I think dollar-wise, about 3 years worth would do a good project, 3 years in total of about 100,000 Canadian, I think it was coming to. 100 to 200. I will double check the cost, but it was ideally over 3 years because then things don't get cut short.
So can you do the gene therapy without that research that you were talking about from Dr. Messias, or is it all?
No, they're just in parallel. They're different and interchangeable. Interchangeable meaning that they would complement. You can learn, one can help the other project. You can learn from each other.
Okay.
So all going to the same endpoint.
Yeah. Okay.
We're doing exactly that kind of approach for other diseases as well, to do things in parallel, because if one thing doesn't come through, you've got something else to fall back on. And as Lee said, you constantly crisscrossing between projects and learning information, which helps move everything forward quicker.
Okay.
There's no redundancy so far in anything, just complementary projects.
Right. So obviously we don't know yet how close we are to finding a gene therapy, because that's, I guess, a couple of years off, or we don't know.
That's a hard question, because it's not only finding the therapy, it's instituting safely. So it's more than just being able to find it and then put it into the mouse and saying there are changes, and still after that there's so many other steps that need to be taken to so it's just a very hard question. And I know we have an amazing gene gene therapy model with spinal muscular atrophy, And that's been our success story in neurology in for the last, I don't know, decade or more than decade, right?
Yeah. I'm always very careful of, you're right, Michelle. There's a lot of, hope in gene therapy at the moment. But there's also this concept of expectation management as well. We want to make sure that we're being realistic and clear with the patient and their families about what the timelines are for these kind of studies. I mean, I've had parents calling me up and saying, do you think you could develop a gene therapy and have it in our children in 2 years? And I say absolutely not, because that would be, it wouldn't be safe. It would be irresponsible. And that does happen. People, you get some people saying, yeah, we can do it, we'll take the money and do it. But I don't think that's the way forward. And the spinal muscular atrophy study, which Sunita just mentioned, that was that's one of the huge successes. That took about, I think, from the start to where it got to 8 years. It might not take that long in your case, because that was one of the first gene therapies coming through, and so we've learned a lot since then, so we can do things quicker. But anyone that says we can do it in a year or 2 years is that's difficult.
So basically, if you have a doctor telling you, give me $1 million or whatever, and I can fix your child in a year, something is not really quite right.
I think there are some things that money can't fix or can't do, and that's one of them, is safety of a drug. Because let's say we do the animal studies, then you have to go to you'll have regulators in your country that control or ask us difficult questions, and that's their job, and I'm glad they do that. And plus with gene therapy, I mean, what we're talking about here is injecting viruses into a human being. And that kind of sounds scary. I hope it doesn't come across as a negative thing. It's a positive thing, because the viruses we use are safe. But in that kind of approach where you can't take it away again, we've got to make sure that we tick all the boxes and really make sure that it's not going to do your children any more harm. We don't want that, absolutely not. So for that reason, these things do take some time to develop. But we're seeing huge successes now in neurology, as Sunita said. Neurology is often was seen as a kind of a dark place once upon a time, and these technologies, when they come through, are really, really enlightening and bring hope to many patients and their families. But it takes time to get that. That's research.
Right.
So it is.
I think that's the important thing. Don't put all your eggs in one basket, right? That's why all these studies have to be done in parallel, because maybe there isn't a gene therapy cure, but maybe there is another medicine that can augment something, that can be used symptomatically, that slows progression. You don't know, right? We don't know any of the answers to this. Right. So I think this is why we need to explore every path, because we don't know till we look.
Is Dr. Santarelli in Italy still looking at zebrafish?
I don't know. I don't know where that stands right now, and I'm happy to ask him again. I don't know. And it is something, so that is also a possibility of something to be done locally, actually. If it's not being done, that is one thing I didn't discuss today, because we're just, we have local funding that might be possible, and a local researcher in that. So it just, that's something that can be explored.
Okay.
Okay, so we had another question, but more of a general remark.
Yeah.
Is there any research linkage towards dementia due to the iron deposit in the brains?
I'm surprised nobody has brought up the iron yet. So iron, as you know, the iron deposition is seen in so many convergence of so many different diseases, right? We know it's in Alzheimer's, Parkinson's, multiple sclerosis, Huntington's. We also know that iron is there's good iron, bad iron packaged differently, a lot of it in the brain, and it depends on how, it has nothing to do with the iron that we consume and that's in our blood. We know that the iron is somehow dysregulated, so it might not be packaged properly. And if it's packaged incorrectly, it can lead to toxic reactions in the brain and cause breakdown of things of different, causing this like reactive oxygen species, it's called, and cause breakdown of many different cellular elements. So yes, we know there's changes in learning in FAHN specifically.
Yeah.
I'm not convinced that the iron is more than just a consequence of the unstable or breakdown of myelin, and perhaps how maybe if, and I'm theorizing here, that if the cells that are producing myelin or the cells involved in stability and the communication between them, if the iron's not being, if those cells are not working, then they're not able to store iron properly or transport iron properly anymore. And then that iron can be in the wrong place. And so I do think that it's not the iron itself, but it's already, whatever the course of the disease was has already happened, and then the iron shows up. And I think what we need to do for moving forward is, if through imaging, look for this a little bit more clearly, going forward, because as I showed you in our study, iron's not there in everybody, especially not early on. And we're already seeing the cognitive regression happen early, right? School changes are happening early. That's not when we're seeing iron.
It's symptomatic more than it's a cause.
That's what I think. I think it's part of it's a consequence more than anything else. So I don't think we should be using our energies to change the iron levels or how iron looks. I think the energy should be focused on how can we prevent that process that's leading to the iron in the first place. This is a very, in the last few days, there's been some really good talks about iron and breakdown of iron, storage of iron. It's very complicated. It's very new, actually. A lot of the papers coming out are from like 2018 and 19, like some of the newest stuff on it. So iron's not a well understood thing, especially in the brain.
Can I ask you a question about something you said in your talk? You were saying that the process of imaging, or the imaging modality, may change one's ability to pick up iron in the brain.
Yeah.
So is it that some hospitals have the technology and some hospitals don't?
I think all hospitals have the technology. I think all hospitals don't use it as a sequence that they would use during the MR. So there are a couple of different sequences. One of them is called SWI or SWAN, and this is able to look at hemoglobin that's deoxygenated. And this is the one we use at our hospital. And we use it on everybody. It's just a sequence that's put on everybody. But a lot of places, even in Canada, don't. And a lot of places around the world we've now seen don't. And it's not an old technology. It's just not used. And so we're trying to advocate for it to be used in everybody. And we're trying to actually research it better here in what normal looks like in kids who aren't affected, just to understand what's going on in those images. Can we see what normal iron accumulation looks like? Because everyone has iron. We all have iron. And it's more and more as we get older. So yeah, we use SWANs or SWIs. Other hospitals may use a different sequence. And again, going back to the animal, I don't know what animal imaging is like in UCL, but what's being used to look for iron in the mice would be something interesting. If, developmental imaging of iron. I don't know if I'm talking way above what can be done, but would be interesting to look at as what changes, what's happening clinically versus what's happening neurochemically.
Yeah, you can do. So we've got a small animal imaging facility where we can image iron, but you can also do this thing called a modified pearls assay.
Okay.
Which is histologically you can pick up iron deposits as well. So
right.
I think we've never tried doing this in the iron mice. Okay. But you're just reminding me of the importance of iron. So we should probably have a look at that in these mice as well, in the FAHN mice.
No, it'd be very interesting, actually. Because I think what we're seeing in many other leukodystrophies is iron as well. So what is the relationship between myelin and iron? Would be an important thing that maybe isn't directly related, but could be related to many other conditions.
Because where I've spoken to Manju about iron and iron add, sometimes she said the patients have them, sometimes they don't. I wonder if it's a similar.
I think
it's a similar issue as you're describing.
I think so. I think the oligodendrocytes are such a big myelin or iron. They retain a lot of the iron, right? They retain. So if there's disruption there, or if there's disruption in some of the, even in, like I said, the supporting cells, because then they're not able to efflux the iron properly. That would be important. So I think it's so, I have to read the papers over and over again because it's so complicated. But I do think this is all like an end result and very different from the autophagy process in BPAN and perhaps what's happening with in PCAN. And I don't know, there was one study looking at iron transporter in FAHN. There was one patient and there was PCAN in that INAD showing there was a problem probably with one of the transporters. I don't know if that's the whole story or if that's again secondary to something.
Any other comments or questions?
Okay, it's been a long morning, I know, for all of you, or a long afternoon or evening. Might be bedtime somewhere. Yeah.
Evening. It's 7:40.
Yeah, it's bedtime.
It's bedtime in Belgium.
Yeah. Good night.
Ik slaap wel. Wat zeggen jullie dan? Emma.
Good night, Emma. We'll see you again. What I'm trying to do is now that COVID has well, it's not over, but things are settling a little bit. I'd like to meet with all of you again. Okay. And anybody, I know that we haven't actually met, Lance, but I'd be happy to formally meet if you were interested in moving forward.
Absolutely, yeah. If any contact information would be great if you want to shoot me an email. I tried to send out a group message to all the other parents through the conference website, and it wouldn't send for some reason. It says nobody is available or whatever. So I would like to put together some communication between the parents if we can, to stay in touch and talk, ask questions, and maybe meet again on Zoom as it goes along. So if anybody is interested in doing that, please send me your email. I put my email in the chat, but I'll tell you again, it's just lswedish@gmail. And I'll put together a list of contact information and share it with everybody else, and we can keep things going.
And I've put mine and my research coordinators as well. Mother is fantastic. So
perfect.
Okay.
We have a Facebook group too, if you want to join. We all keep in contact.
Absolutely. Yeah, this is all, I mean, this has been great information and things that we've been looking for and just haven't stumbled upon yet. So I'm really grateful to everybody sharing whatever they can.
There's lots more families on our Facebook group too. I don't know why they didn't join the conference, but there's lots.
Yeah.
Well, I mean, considering it's FAHN, it's not really lots, but more.
Great.
Yeah.
Well, it's a pleasure seeing everybody. I know you all want to get back to your days. So I am reach out anytime. Okay.
Thank you.
It's lovely seeing everybody. And hopefully
Thank you.
we see each other in person next time.
That would
Thank
be
you very much.
Okay.
Bye.
Everybody.
Bye.
Bye. Thank you, everybody.
Thank you all. Bye-bye.
Thank you. Bye.